Again, I want to welcome everybody to Managing Joint Pain, Discovering Hip Relief. Today's event is brought to you by the Cleveland Clinic in partnership with the Arthritis Foundation. Again, we're just going to allow for a little bit of time for everybody to come in and get settled in. It's going to be a wonderful event here, and so excited to offer you this event. I'd like to take a moment to just introduce myself. My name is Deanna Makota. I'm a marketing associate here for the Cleveland Clinic, and I'm your host for today. And I have the pleasure of introducing our presenters as well as moderating our Q&A segment, which we're going to save for the conclusion of our presentation. Again, I would like to formally welcome everybody to Managing Joint Pain, Discovering Hip Relief. Hopefully everything is sounding okay and you are able to view our event with no issues. To give you a brief rundown on today's event, we're going to start with new advances in hip replacement techniques, which is then going to be followed by non-surgical arthritis treatment options, and again, a live Q&A. So many of you had submitted wonderful questions upon registration. I want to share with you that those questions were sent to the presenters and many of them incorporated into the presentation. And those questions that are still lingering, we will go ahead and ask those. But if you have any questions, you can feel free to go ahead and put those in the Q&A. Speaking of, I do want to bring to your attention this chat function for today's event. We're going to be offering you some excellent resources in this form as well. So there's going to be additional articles, more information about Cleveland Clinic programs and about both of our presenters today. And then again, we're going to be answering those questions for you. Also, if during the event you find that you love our presenters, which I know you will, and you're ready to move forward with an appointment, we're going to be offering you a way to go ahead and move forward with scheduling an appointment, and somebody from the Cleveland Clinic will reach out to you. As I had mentioned, today's event is brought to you by the Cleveland Clinic in partnership with the Arthritis Foundation. And I want to share just a little bit about the Arthritis Foundation in case you are not familiar with this wonderful organization. The Arthritis Foundation offers just so many wonderful resources from people that are trusted resource for you, for your loved one. They offer services ranging from helping assist in interpreting your insurance coverage to offering a platform to connect with those that might be struggling with similar issues, as well as many local and national events. I know locally here in Cleveland, there's going to be a Walk to Cure Arthritis, which is going to be happening in fall. Just so many wonderful events and so much more. In, again, that chat function, you'll see a handout section. There is a handout on the Arthritis Foundation and all of the resources that they have to offer. I strongly consider reaching out to them if you need a little bit more assistance, if you need anything further. It is a wonderful resource to have at your disposal. And without further ado, I'd like to go ahead and get started. And it is my great pleasure to introduce to you Dr. Daniel Harmon. Dr. Harmon is an orthopedic surgeon specializing in adult reconstruction of the hip and knee. He graduated from John Carroll University, go Blue Streaks, and prior to attending his medical school at LeCom in Erie, PA. Dr. Harmon went on to complete his orthopedic surgery residency here at the clinic, and he has extensive training in minimally invasive muscle-sparing surgical techniques for reconstruction of the hip and knee. He is an experienced instructor and has taught this technique to surgeons locally and nationally on anterior total hip replacement. But most importantly, Dr. Harmon provides caring and compassionate treatment with an emphasis on conservative treatment measures prior to surgical intervention. Dr. Harmon, that's quite the impressive bio. We are so honored to have you here today. Welcome, and thank you for joining us.
Yeah, thank you very much for the nice introduction. I appreciate it.
Absolutely.
My name's Daniel Harmon. I'm orthopedic joint fellowship surgeon at the Cleveland Clinic, so total hip and total knee replacement. Thank you all for coming today. Really appreciate it. I know taking time out of your day to come and hear about this is a big opportunity. I hope you guys take something out of it. I hope that all your questions are answered at the end. And without further ado, we'll get into new advances in hip replacement techniques. So first slide here, residency, as she noted, I went to Cleveland Clinic here I graduated in 2013 from the residency program here. then went on to complete a fellowship in hip and knee reconstruction at Allegheny General Hospital in Pittsburgh, Pennsylvania. So I spent a year of my life just kind of training in hip and knee, total hip, total knee, and then also revision total hip and revision total knee. I then went on, I was in Fort Myers, Florida. I was in private practice in Fort Myers for 8 years, and then had the honor to come back and now join the staff here at the Cleveland Clinic in September of 2022. So when we talk about the hip is a complex joint. There's a lot of muscles, tendons, ligaments that attach to it. But for the purposes of this talk and for the purposes of arthritis, we could break this down into basically two simple things. Number one, the femoral head, or the ball of the ball and socket joint. And then the acetabulum, or the socket side. When we talk about the hip, we talk about articular cartilage, or really any joint in the body. So at the ends of joints, we have articular cartilage. This is hyaline cartilage. So this is smooth, glistening cartilage, this white cartilage that you see on the screen that allows joints to glide easily against one another. What happens in arthritis, or degenerative arthritis, is that articular cartilage, or that nice white cartilage that we see, that tends to degrade over time. This is your typical wear and tear osteoarthritis. And as it wears away, we become to have this area of degeneration of that hyaline cartilage. And that degeneration allows for exposed bone on either side of the joint. When you get this exposed bone, this is what creates pain in the joint. So on any joint. And once that bone on bone situation happens, that's what's innervated by nerves. And that's when people start to experience the symptoms that they are having in their hip or finger or knee or wherever it's at. So consistently, what are the symptoms of hip arthritis? Most of the time, people are going to come into the office and they tell me, "Doc, I got pain in my groin." So that's the most consistent symptom. A lot of people end up saying, "Oh, I thought it was a muscle pull," but that pain in the groin is very reproducible. That pain in the groin is consistent when people have hip degenerative arthritis. Also, the more people walk, the more people hurt. So usually if somebody's telling me, "Yeah, it hurts worse when I'm lying down at night," I'm not really thinking I'm not thinking along the lines of hip arthritis. I'm thinking maybe back. As far as the other symptoms, getting in and out of a car, very consistent. People come in to the office and they say, "Every time I get in and out of my vehicle, my groin causes me pain." So these are just some of the things that come up when somebody's coming in for evaluation of their hip. So how do we diagnose this? So you come to the office, sit down. Obviously, we have to do a physical exam. And the most consistent physical exam finding is pain with internal rotation. So internal rotation is this picture over here on the right-hand side of the screen. We flex the hip up and then internally rotate it. And patients will have reproducible pain in the groin with this motion. And this is really one of the main findings that I look for on an exam. As far as other questions that I get in the office, so everybody comes in and asks, "Am I ready for a hip replacement?" And really what this comes down to is we sit and we have a discussion and I say, "Listen, it's not a heart attack, it's not stroke, it's not cancer, it's not something we have to operate on. Is it preventing you from doing things that you want to do in your life? Does it wake you up at night? Do you find yourself modifying activities that you used to do and you used to enjoy, and now we're not doing those things anymore because of this pain in your hip? What's a comfortable walking distance for you?" So, I'm more of a conservative approach type of guy. I like to try and exhaust all options prior to proceeding to a surgical intervention. I let people tell me when they want a hip replacement. So, I never tell them, "Hey, yeah, you need a hip replacement." It's an elective operation. So whenever you're ready, that's a discussion that we could have together. That's a discussion that we could come to, or that we could have and then come to a decision together in the office. So what do we look for diagnosis on x-ray findings? Number one, we look for, so this is a just picture of a pelvis. If we look over on your left-hand side of the screen, that's the right hip. And then on the opposite side, that's on the right-hand side of the screen, that's actually the left hip. So we could see the difference between these two pictures here. So this joint over here, femoral head and socket, and then this hip, you can see decreased joint space. So that space up top where this joint space is over on the right-hand side of the hip. We don't see that over here on the left. So that's like our first sign of any type of arthritis on an x-ray is decreased joint space. We also see sclerosis. The sclerosis means this whitening of the joint line up top. That's from increased bone turnover. So as people put extra stress across the hip, the bone tends to turn over and that shows up white on x-ray. The other finding that we see is we see these bone spurs, or these little osteophytes is what we call these. So this happens as you get increased contact stress across an area. The body tends to increase surface area to decrease the contact stress. So basically the body's just trying to form new bone to protect the joint itself. And also we see these cyst formations, this little black mark at the bottom of this, the ball over here. And that's called degenerative cyst. That fills up with fluid, and that's also from long-term arthritis. So 4 X-ray findings that we look for, and then also the physical exam findings. So what are some of the non-operative treatments that we could do? So number one, non-steroidal anti-inflammatory drugs. So we all know what those are as far as over-the-counter medications like Motrin, Aleve. I like to use 2 different prescription medications, either Celebrex or Mobic. There are contraindications to this. So if you have kidney disease, liver disease, heart disease, previous history of heart attack. So if there's none of these contraindications, this is a good first-line treatment, or at least the first step in treating any itis or any inflammation, including arthritis. The other thing that we could do is we could do a steroid injection inside the hip joint. So this really depends on, number one, symptoms. So how bad is it? Number 2, how much arthritis is there on X-ray? Some people get 2 weeks relief. Some people get 3 months. Some people get 6 months. I mean, we never know until we do it. Everybody responds differently. And it also depends on how much arthritis is there in the first, initially. So the one caveat that I tell patients is that, if we elect to proceed with a steroid injection and say, we're hitting a home run for a week or 2, and then you say, wow, that was awesome. I felt so much better. I would love to move forward with a total hip replacement. We do have to wait 3 months from the time of the injection to the time that we can proceed with a total hip replacement. Reason being that it does increase your risk of infection. So that kind of magic time frame is 3 months from the time of injection to the time of surgical intervention. If the patient's okay with that, then I'm okay with that. As far as other things that we could do, so aerobic exercise and weight loss. So if we look at the force on the hip per step, it's equivalent to approximately 6 times a person's body weight. So if we say 16 pounds of body weight, additionally, this could add up to 100 pounds of force on the hip each step per day. So if you say 2,000 steps per day for the average person, which most people take much more than that, but if we say 2,000, this is an additional force that could equal up to 100 extra tons on each hip per day. So somebody online figured out that was the weight of 13 elephants. So I thought I'd include that. But that's a lot of force across the hip. Now, one thing I did want to mention on that slide is that certainly with arthritis, it's hard to exercise, right? So you can't go out and do the things that you want to do typically to lose the weight and to have that aerobic activity and that cardiovascular activity. So one thing that I really concentrate on is aquatic therapy. So getting into a pool is excellent for any type of arthritis, whether it's knee or hip. It takes gravity out of the situation. And this way you're able to raise your heart rate enough to expend the calories and get your heart rate up enough in that zero gravity situation. So when it comes to surgical treatment options, what are our options? And when we look at hip arthritis, basically we have a total hip replacement. So this is the parts of a total hip replacement outlined here, and there's going to be a schematic coming up. But as far as the total hip replacement itself, there's a cup that we put inside the pelvis bone. There's a plastic piece that sits inside that cup. There's a stem that goes down the middle of the femur bone, and then we put a ball on top of that stem. This ball and then articulates with this new plastic piece, and that becomes the new bearing surface. So that removes the arthritis out of the joint, removes that damaged cartilage, and this now acts as your new bearing surface. So either ceramic on plastic or metal on plastic. So if we remove the skin, we get down to the muscle, take away the muscle, and we're down to the bone. Once we get down to the bone, we remove the ball of the ball and socket joint in surgery. We put a new cup in the pelvis. Inside of that cup sits a plastic piece. Down the femur bone, we put a stem, and then on top of that stem, a ball. And then those two articulate with one another, and that becomes the new bearing surface. So this is just a picture I threw in here. So as far as when you come to the office, we have x-rays completed. And if we decide together that, you're ready for a total joint replacement or you're ready for a total hip replacement, one thing that we do preoperatively is we're able to use these templates. We're able to use computer imaging to determine exactly what sizes and give us an outline of what we were going to place at the time of the operation. So this is called orthopedic templating, and we're able to determine exactly what size cup, what size stem, and then also determine where we're going to cut the femoral neck, which is this area here. And this is the area of bone that's completely removed at the time of the total hip. So measure twice, cut once type of thing, but this does give us a good outline and something that we could reproduce at the time of the operation. So what are our goals of hip replacement? Obviously pain relief, an improved function, improved quality of life, and then ultimately a happy patient. So total hip arthroplasty, if we look at this across the board, it's one of the most successful operations in the history of medicine. Over 95% of patients experience complete pain relief. It's one of the most common surgical procedures that we perform in the United States, 450,000 done annually. Excellent long-term survivorship, 25 to 30 years. And what I mean by that is the implants, how long they typically last. Low complication rate of 1 to 3%. So I always tell my patients, listen, there's a low complication rate of 1 to 3%, but if it happens to you, it's 100%. So certainly anytime we cut on the skin, anytime that we do surgery, there's always a risk involved, but there's not a lot of things in medicine that we could say that we're getting A's on routinely. So it is a good operation. So if it is such a good operation, it would beg the question, is there room for improvement in total hip arthroplasty? And this guy would probably say yes. So if we look at current improvements, number one, advanced surgical approaches. Number two, multimodal pain management, anesthesia. We'll talk more about this in the upcoming slides. And then, as I mentioned previously, this implant longevity. So the implants that we put in, how long are they lasting? And then also the wear properties of those implants. So pain control and anesthesia. So prior to the operation in the preoperative area, even prior to getting to the preoperative area, when I see you in the office, I usually order preoperative rehabilitation. The reason I do this is because I think better muscle control, better balance is going to make for a much better recovery post-operatively. So the stronger you are going into an operation, the better you're going to be afterwards. In the preoperative holding area, we give you a couple of different medications. We give you oxycodone for a preoperative narcotic medication. We also give you Celebrex if it's not contraindicated, which is an anti-inflammatory medication, which also helps with pain afterwards. And then Decadron, which is a steroid. We give you one shot of this prior. This helps with both nausea or any vomiting that you may have after the surgery, but it also helps with inflammation as well. During the time of the operation, so intraoperatively, we give you a pain cocktail injection. We inject this around all the muscles of the hip and the capsule of the hip. We also tend to do a spinal anesthetic, not a general anesthetic. The reason I like to do this is, number one, it's shorter acting, so it lasts for about 2 to 3 hours. So we numb you from the waist down. After the spinal wears off after the operation, about 2 to 3 hours, you're able to get up and start walking, and you also don't have those same side effects as you would with a general anesthetic. So you're not nauseated, vomiting, groggy after the surgery. It wears off, and then you're able to get up and start moving. There's also studies to show that it helps with decreased blood loss. It also decreases your risk of infection, as I mentioned, less nausea, vomiting. And then there has been a decreased length of stay associated with a spinal anesthetic versus a general anesthetic. So what's to say about this is that it's a team effort. It's not just the surgeon, it's the OR nurses, pre-op nurses, PACU nurses, the anesthesia team, all of these people working together to make sure that we get you the best hip or knee that we could possibly get you. We get one chance to give you the best knee or hip, and we want to make sure that we're doing everything we can to do that. So as I mentioned, implant longevity. So polyethylene, or the plastic piece that sits in between. So this plastic piece that you can see on that right side of the screen, industry has really focused on making this plastic wear at a much lower rate. So what could happen with the 20 years ago or 30 years ago, this plastic would wear and it would create little debris in the hip, and then it would cause problems with the actual implant itself. Now we expect at least 25 to 30 years out of these. Now, certainly it all depends on if you're doing a total hip replacement in somebody, 40 versus 60 versus 80, the overall activity level is going to be different. And also, you're out trying to run marathons on it, or, you're doing normal activities, and it's going to wear at a different rate. But overall, as a general guideline, I tell my patients 25 to 30 years is the life expectancy of this plastic. And we do have industry really to thank for that. So some of the traditional approaches to the hip, posterior approach, which basically means you're going through the back of the hip, a lateral approach where you're going through the side. There's an anterolateral approach, which is a mix between front and side, and all these approaches work. And I think that the most important thing to take home is that comfort with your surgeon and comfort with the guy doing it or girl doing it is the most important thing. So whoever is treating you, whatever approach they use, as we said, it's a 95% success with total hip replacement. And I think that all of these approaches are good approaches to the hip. The one that we're going to talk about a little bit more is the direct anterior approach. Get into that next slide. These are some of the traditional approaches. As you can see, these are basically just anatomical images showing that with those traditional approaches of going through the side or going through the back of the hip, they do have to detach muscle or tendon off of bone, and that has to be repaired at the end. As far as newer approaches, which is what we're going to be talking about in more detail here, is the direct anterior approach. And the reason I like this approach is, I don't like the term minimally invasive. It's kind of a catch-all, and it's thrown out there more than I think it should be. But at the same time, this direct anterior approach to the hip, it really truly is a minimally invasive approach to the hip. The reason I say that is because instead of having to detach muscle tendon off of bone and then repair that at the end, we're able to go between muscle planes. So again, this is the picture of the muscle underneath the skin here, and we're able to move this muscle this way and this muscle this way. So we move them to the side to get down to the hip joint rather than having to detach muscle and tendon off of bone to get down to the hip joint. Now, these muscles can just kind of fall back into their natural plane afterwards. As far as the questions that I get in the office, am I a candidate for a direct anterior total hip replacement? And in my opinion, I've never done a primary total hip replacement any other way than a direct anterior approach. So I believe all patients that are candidates for total hip are candidates for direct anterior total hip. Now, that being said, for all joint replacements, we do a lot of different screening prior. So we look at body mass index, and we want this below 40. So this is a measure of your height to weight ratio. The reason we want this below 40 is because we know that over 40, your risk of an infection increases substantially, in some studies upwards of 23 times. So if an infection in a total joint could be a very bad thing. So we want to make sure that we try to mitigate those risks prior and do all we can to optimize you prior to receiving a total hip or a total knee. We want to make sure that you see a medical doctor and you get medically optimized. If you're diabetic, we like a hemoglobin A1C under 7.4 or around there. We know that anything higher than that is typically going to increase your risk of an infection. We check all of your labs, so blood counts, liver function, kidney function prior to the operation. And I typically order dental clearance on most of my patients. If you go regularly every 6 months, that's fine. But if it's been, a decade since you've been to the dentist, it's good to go prior to the total joint, because if there's any infections that are underlying in your mouth, those infections can spread right to the total joint replacement and cause a real problem for you. So we want to make sure that we could get all that checked out prior. Now, as far as a team effort for optimization, so that's one of the great things about working at the Cleveland Clinic. It's, if you have a BMI over 40, we don't just say, hey, lose some weight, we'll see you in 6 weeks, good luck. So we have a whole team dedicated to helping you with this. So there's a dietitian, nutritionist, we have special physicians that see you, that get you ready for your joint replacement and work with you and develop a plan together. So there's a ton of resources that patients could utilize here at Cleveland Clinic to achieve these best possible outcomes. Again, one chance to give you the best possible hip we could give you, and we want to make sure that we're doing everything we can to make it successful. So again, this is basically what I've been harping on. So 1 to 3% risk of complications, and anything we can do to mitigate that preoperatively is a win. So at the time of total hip replacement, I use this table. It's kind of a crazy looking table, but it's called a handed table, and you're placed in these boots at the end of the table. They look like ski boots, and you're able to be kind of suspended in the air, and this allows us to access the front of the hip. Now, what this table does, this is a picture from intraoperatively, and what this table does, it allows the nurse at the end of the table here to manipulate the leg and move it in different directions in order for us to gain access to specific areas of the hip. So it acts as another assistant within the room. Some guys do it with without the hand table. That works too. I was trained, in both, but I chose to use the hand table, but they both work fine. The reason I do like to use it as well is because at the time of the surgery, so intraoperatively, we're able to bring X-ray in underneath you and take a couple shots with X-rays to make sure that we're putting these components exactly where we want them, and putting them where we templated based off of those preoperative templating pictures that I showed you prior. So we're able to make sure that we have it exactly where we want it before we're walking out of the operating room. With a direct anterior approach, one thing is there's less soft tissue disruption. So why I think this is important is because there's no dislocation precautions. So afterwards, you don't have to worry about the way you twist, bend, pick stuff up off the ground, bend your leg during ambulation or during your gait cycle. All of these things allow for an early recovery for the patient because they don't have this in their head that they have to watch every way that they move. So I think this is a huge benefit to direct anterior total hip replacement. I tell my patients you have no precautions afterwards other than getting in, some crazy yoga pose where you're trying to wrap your foot around the back of your head or something. So other than that, you're good to go and do whatever you like afterwards. Now, certainly it's going to take time to get the muscles back to where they need to be. So, all of these things happen over time, but same point is first day, you don't have any precautions at all. So with that, so here's a patient of mine that I did in Florida.
So post-op day one.
This is post-operative day number 1. She was shuffleboard champion.
Very good.
Really nice lady.
Good job.
Believe me, just in case they don't believe it, because I don't.
Good job.
Oops. So if we look at a couple of studies, if we direct anterior approach versus a mini posterior approach. So a study looking at going through the front of the hip versus going through a small incision in the back of the hip. We looked at basically 200 patients and they split them down the middle, 100 through the front and 100 through the back. And then at 3 weeks, they looked at these patients and direct anterior patients had better single leg stance, gait, 50-meter walk, and less use of walking aids. And that's not to say that a mini posterior approach is a bad approach by any stretch of the imagination, but I think in the early recovery period, there's certainly a difference between the approaches, and I think the literature would support that. If we look at pain scores, anterior approach patients, they routinely do have less postoperative pain and they use less narcotics. I like that. Less medication means less side effects. So that is an absolute win if you're not taking narcotics afterwards and you're able to manage this with more conservative Tylenol or rotating Tylenol and Celebrex and not having to take these medications like narcotics afterwards. If we look at another prospective randomized study, 2 surgical approaches to total hip, again, 100 patients, and then split them down the middle again, 50 direct anterior and 50 direct lateral. And they looked at the patients at 6 weeks and then 8 weeks. The direct anterior patients, they had better pain scores and better hip function scores. And if we go out long-term on this, though, 6 and 12 months, both groups had the same pain and same function. So this takes us back to the point again. It's a good procedure, a total hip, and I think at 6 and 12 months, you really can't tell which way you did it, and the comfort with the surgeon that's doing it is very important. Length of stay in the hospital. So decreased length of stay in the hospital. National Medicare average length of stay for total hips is 2.7 days. So my experience has been that majority of my patients are able to be discharged to home the same day. Now, that's not to say that like anybody's going to kick you out of the hospital if you're not safe. We want to make sure that you're safe, you're able to meet physical therapy goals, you're medically stable. But if all those things add up, the truth is people recover much better at home than they recover in a hospital setting. So if you're able to get home, then I'd say get home. That's a win. You're able to recover in the comfort of your own home, and then also have home healthcare come out and work with you for a couple of weeks afterwards. We usually see you back at the 2-week mark, which I believe I get into here too. So some of these post-op videos. So here's a patient. This is one of the anesthesiologists, her husband, that I did a total hip on.
First day after surgery, new hip.
Walk down there.
Walk this way.
Easy.
Huh? I can't stop.
Stop. I'm sending this to Dr. Harmon. All right, come back. Great.
I could probably golf by Friday, I bet.
All right, yeah.
That's my favorite part. I could probably golf by Friday. Okay. And then here's those patients were both post-operative day number 1. This patient's 2 weeks post-op.
Very good. 2 weeks.
So, like I said, discharge to home, whether that's day 0, day 1, whatever it is, whatever makes you safe. And then at 2 weeks, you come back and see us in the office, and the follow-up appointment, we kind of evaluate you, see how things are coming along. And then if we need outpatient physical therapy, then we'll order it at that point. A lot of times what I tell patients is, I want you to just walk. So 20 minutes, a few times a day, get up and walk. Sometimes, therapy can overdo things if there's if there's any contraindications to it, like we just kind of go over that in the office. But a majority of the time, I really don't order a lot of outpatient physical therapy for total hip replacements at the 2-week mark. So I appreciate everybody's time. I hope you enjoyed it. Thank you very much, and we appreciate y'all being here.
Wow, Dr. Harmon, thank you so much. What a wonderful presentation. I personally love the videos as we were doing them. I really love I'll be able to golf on Friday. I love that. And she's just like, yeah. So thank you so much. What a wonderful presentation. Dr. Harmon's going to go off camera just for a little bit, but he's going to return for our live Q&A. I thank all of you for posing some wonderful questions. Hopefully we're answering some of those questions that we can. We're going to ask those questions of Dr. Harmon in our next presenter, and so he will return. So without further ado, I would like to introduce Kaityln Gasser. Kaityln, thank you so much for joining us. I'm going to briefly introduce you now. So Kaityln Gasser was born in Ohio here and graduated from Messiah College in Pennsylvania, where she, of course, graduated summa cum laude. She returned to Ohio to complete her physician assistant training and graduated with a Master of Science from Cuyahoga Community College and Cleveland State University. She began her professional career in rheumatology in 2019 here at the Cleveland Clinic and provides care in collaboration with the excellent rheumatology physicians in our Rheumatologic Institute. Her specialties, and just some of them, include joint pain, rheumatoid arthritis, psoriatic arthritis, osteoarthritis, and osteoporosis, as well as bone health. And again, that's just a few. Kaityln, thank you so much for joining us. Thank you for your time and dedication to this event. And without further ado, please join me in welcoming our next presenter on non-surgical arthritis treatment options.
Thank you. As Diana suggested, my name is Kaityln, and I'm here to talk to you a little bit more about the non-surgical approaches. A little bit about myself. I am a physician assistant, and I have almost 4 years of experience in rheumatology. I primarily split my time between Independence Family Health Center and the Medina Medical Office building, and I work about 3 days a week. Want to just start my presentation by kind of getting a better idea of what a PA is, who I am, and because you may experience or interact with PAs throughout your time as in treatment for osteoarthritis. And basically, we're highly trained clinicians and healthcare professionals who practice medicine. We can practice in any specialty or any setting. The purpose of our role is to help expand access to care, transform health and wellness, and provide patient-centered, team-based medical practice. In terms of what can PAs do for osteoarthritis, you could see us in many different areas. You could see us in your primary care office. If you start there for hip pain, we might be in orthopedics, rheumatology, and on and on. We can do an initial evaluation of new joint pain, kind of as Dr. Harmon suggested. We can do a history and physical exam and help you make that diagnosis of arthritis. We can discuss different treatment options. We can place appropriate referrals if needed, and we can prescribe medications as well, if that's appropriate. Other PAs, I personally don't do this, but in orthopedics especially, there are PAs that will be first assist in your surgery or follow-up or post-op appointments as well. So we're just part of the healthcare team. We work closely with the docs in our specialty, and we're here to kind of help it make it easier for you to get appointments when you need it and take care of your joint pain. Who is this talk for? We're focusing primarily on osteoarthritis for this talk. So osteoarthritis, like Dr. Harmon suggested, is just a mild form of, or not a mild form, it's a form of wear and tear or degeneration of that cartilage. And so this is for that type of arthritis. There are multiple other forms of arthritis that we're not going to talk about today that rheumatology also manages. And so I'll talk a little bit on the end, but this is primarily for osteoarthritis. And so also this is for patients that have health conditions that may limit their ability to have a total joint replacement, or just aren't quite ready to take that jump into surgery. I'm not going to spend too much time here because we've already spoken on this a little bit, but as we discussed, osteoarthritis is just that wearing down of the cartilage, the narrowing of the joint space, and pain from some of that bone rubbing on bone and irritation. I want to take time to split my talk a little bit on both the physical, psychosocial, and mind-body approaches, as well as pharmacologic. The physical, psychosocial, and mind-body approaches are often over or underlooked, appreciated, underappreciated, overlooked, easy to kind of skip on and think, oh, what can I take for my pain? And they're so important in management of arthritis. It's usually very heavily arthritic pain, and pain from arthritis can be heavily intertwined with mental health and activities of your day-to-day life. And so it's important to kind of focus on these aspects instead of just taking medicine for the pain. Anytime you see two little asterisks next to something, that means that there is a lot of high quality, very well done studies that show that this is a good treatment option for arthritis. And so the first one I want to focus on is exercise. A lot of times people come and they ask me, well, if this is due to wear and tear, if this is due to, degeneration, won't exercise make it worse? And actually, data suggests otherwise. I don't know that it's 100% the way that the mechanism could have multifactorials. We don't know exactly why it helps, but my thought process is if you build up the muscle strength around that joint, you're going to improve the mechanics of the joint. You're going to improve the strength of the joint, which is going to also help protect it and help the pain of that joint. And also it has a lot of effects for mental health too, when we're exercising and active. So that also probably helps. In terms of what type of exercise is best, I get this question a lot as well. And ultimately, there's not really enough data out there to say this exercise program trumps another exercise program. Really what we know is that across the board, patients that exercise versus patients that don't do better. And ultimately, it's about what you have access to. It's about what you enjoy doing. It's about what you actually practically are going to be able to do. Some of the studies do suggest that patients that have like a supervised program, such as like a physical therapist that's guiding their treatment, or a group exercise program, might do a little bit better than those that are individual. But not everybody has access to that, and that's not necessary to get benefit from exercise in arthritis. Like I said, some options are walking is one of the most common studied types of exercise for the hip and knee, but also stationary bike, weight machines, those all have shown to be helpful in arthritis management and pain. And also aquatics is a really great form of exercise for patients, especially if they have a lot of pain from hip arthritis, because that takes some of the weight off of the gravity off of your body and helps alleviate and move those legs and move those muscles without as much stress or strain on that joint. And that can be done again through a self-directed program, through a class, or even through physical therapy. We do have physical therapists that specialize in aquatics. Along the same line as the exercise is the weight loss. As we know that even as small as 5% of weight loss can be associated with improvement in your clinical outcomes. And we see that it is a dose dependent, or it kind of depends on how much you lose. Generally speaking, the more weight you lose, the more your pain will improve as well. Again, the reason for this is that your body is carrying less physical weight, less strain on that joint, but also, weight loss is typically associated with the regular exercise program. So could it be the combination with the exercise as well that's playing a role? Possibly. Regardless, there's a lot of data to suggest that it is very important an option if you're really looking to maximize your non-prescription or non-surgical options. And I should preface too that this is primarily for patients that may struggle with like being overweight or obese, not necessarily for those that are at a normal healthy weight to begin with. Focusing a little bit more on the mind-body or psychosocial approaches. Again, arthritis causes pain, and pain is a really difficult thing for a lot of patients to deal with. It limits you in the ability to do things you enjoy. It affects your day-to-day, and it can cause some thoughts of, depression or, just struggling with mood. And that's totally understandable, totally reasonable. And so that's why these types of things are also important in managing your arthritis. One specific program that's been studied in high quality studies and has shown improvement is Tai Chi. Tai Chi is a traditional Chinese mind-body practice that combines meditation, slow, gentle, and deep diaphragmatic breathing and relaxation. It's focused on helping, improve strength, balance, and also helps with some of the kind of a meditative approach, and helps a lot of patients with their mental health as well. And so it is a good option, and you can look around for different classes or people that can help you in that. Some of the less common ones that are still options for you may not be they don't have quite as much evidence basis behind them, but are still worthwhile to consider. Yoga has been shown to be good for knee arthritis. There's not a lot of studies for hip arthritis, so I wouldn't say that that's particularly evidence-based recommendation. But again, any form of exercise that gets you moving, something that you enjoy, I would say it's worth considering. If it's not something you like, don't do it. I wouldn't recommend it for everyone. And then cognitive behavioral therapy has been shown to be very beneficial for patients that suffer with pain in a lot of different forms, including osteoarthritis. And really, it's just, it may be that it's helping patients kind of accept their diagnosis and find ways to cope with the pain, and just also to find ways to help with, some of the mental health struggles that come with living in pain. So definitely worth a consideration, if some of the other initial things have failed and you feel that you may benefit from talking with someone about, managing and struggling with the pain. Acupuncture, again, it has been shown to be helpful in a lot of other chronic pain disorders. Not so much, there's not as much data in osteoarthritis, so I can't say there's a strong evidence there, but some patients do find relief, especially if they are kind of not a candidate for much else, or really just are looking for less, avoiding medications and prescriptions and other things. So assistive devices, so especially in pre-surgery and for painful hips and knees, as when you're walking funny or favoring your leg to try and avoid putting pressure and weight on that painful joint, it can kind of put you off balance and put you at risk of falls and things like that. So a cane is good and helpful in helping try to take some of the strain off that and also keep your balance. And then knee braces, that's not really applicable to hip arthritis, but there are certain knee braces for patients that struggle with osteoarthritis of the knee. And so that may be worthwhile discussing. But I would say having a discussion about knee braces would be warranted with a provider to figure out which one is best for you. And so that's the majority of what I have for the some other things that I want to mention that I didn't really put on the slides, but that might be worthwhile. A healthy diet that's going to help you with weight loss. I also often talk to my patients about anti-inflammatory diet. Don't know that we have a lot of good evidence-based data to support that, but a lot of my patients do report feeling better if they cut out a lot of, high processed carbohydrates and things like that and focus on a very well-balanced diet, or a Mediterranean diet is a good option as well. So something to consider, again, if you're really looking for a more natural approach. In terms of pharmacologic or medication approaches, I'm going to start with the most common and then kind of touch on some of the others as we go on. Couple different forms of medication. Oral meds obviously are the most common we think of, but then also topicals and injections are also different things to consider. In terms of the oral medications, one of the most common forms of over-the-counter pain meds are non-steroidal anti-inflammatories, often called NSAIDs. Ibuprofen, naproxen, lots of different name brands for these, but active ingredient of those, it doesn't matter the name brand. If it contains ibuprofen or naproxen, that's an over-the-counter NSAID. And then there are plenty of other prescription forms as well. Some of the most common being meloxicam, Celebrex, celecoxib, diclofenac, and etodolac. Generally speaking, they are fairly interchangeable with each other. I would say if you find that over-the-counter is just as helpful to you as prescription, you may save money by using over-the-counter. And it's not that one is necessarily better, but there are some benefits of taking the prescriptions, meaning like they aren't needed as often or as frequent to give more prolonged benefit. But those are options to discuss. Some of the benefits of non-steroidal anti-inflammatories, they are the most effective over-the-counter medication for osteoarthritis. They can treat both the pain and the inflammation in all forms of osteoarthritis, hip, knee, hands, shoulders, wherever it is. But unfortunately, these are not appropriate for everyone. They do, just because something is over the counter doesn't mean it's risk-free or it's safe for everyone. And so it really is important before taking anything over the counter long-term or frequently to have a discussion with your primary care doctor or someone that's managing your arthritis to really see if these are safe for you. Just to kind of touch home on that point, some of the more serious risks associated with the NSAIDs are heart attack and stroke, gastrointestinal bleeds or stomach ulcers, kidney damage with long-term use or high doses, serious skin conditions. And unfortunately, in our arthritic population, a lot of our patients are over 65. And when you're older than 65, we do know that you have a higher risk of complications from NSAIDs. So again, just because something's available over the counter doesn't mean it's safe to take long-term use for everybody. It really needs to be discussed with the primary care provider. Who should avoid NSAIDs? I generally recommend anyone that has history of heart attack, stroke, or coronary bypass surgery should really try to avoid it. Not to say it's a complete contraindication in all those situations, but I really, if there are alternatives, I would prefer to pursue those. Same thing with history of stomach ulcers. If you've had a stomach ulcer or a GI bleed in the past, you're more likely to have them again with NSAIDs. Uncontrolled high blood pressure is another one. NSAIDs can cause you to retain fluid and cause that blood pressure to go up, again, relating to the heart attack stroke risk. So if you're really struggling and getting that blood pressure up and down and you're taking these, your primary is putting you on all these other medications. Maybe make sure you tell them if you're taking these NSAIDs, because that could be part of the reason it's hard to manage. Anyone that's got history or pre-existing chronic kidney disease should really avoid NSAIDs as well. There's no cure for chronic kidney disease, and so the best thing you can do is to avoid something that's going to make it worse, and NSAIDs definitely can do that. If you are currently taking a blood thinner or on chronic steroids for another medical condition, this increases your risk of bleeding again, so reason not to avoid NSAIDs, or at least not take them until you talk with your healthcare provider. And then pregnant patients should really avoid NSAIDs as well. So alternatively, the only other over-the-counter Oral medicine is acetaminophen, also known as Tylenol. It's generally safer for pain medicine for patients with history of heart disease, high blood pressure, history of stroke. Unfortunately, it's not near as effective in osteoarthritis pain. It really only treats pain. It doesn't have any anti-inflammatory properties. And the risks of acetaminophen are that there is a risk of serious liver injury if you take more than is advised on the bottle. Dose of acetaminophen is very important. It's kind of got a narrow window of safety. Once you get over that 3,000, 4,000 milligrams a day, you are playing with fire in terms of risk of liver injury. And so really try to keep your dose less than 3,000 milligrams a day, and don't take more than 1,000, maybe 1,250 at one time. I often get patients telling me they're taking more than they should, and I just really want to be cautious. The other thing about acetaminophen is that it's also commonly in other, sometimes in post-op pain meds, other cold and flu medications over the counter. So, it's easy without realizing it. If you're taking acetaminophen regularly 3 times a day, and then you also take something for cold medicine, you really should be looking at the bottle to make sure you know if there's any extra acetaminophen in there or not, because sometimes people can accidentally get too much acetaminophen in that way. So just be aware of what's in your other medicines, and especially those combination cold and flu meds. Another note about the Tylenol or acetaminophen is that generally I say try it. If it helps, great. Don't be afraid to use it as long as you're taking it as advised. But if it's something you're taking it 3 times a day at the max dose and you really don't feel like there's much benefit, then why put something in your body that you don't need? So it doesn't hurt to try, but if it's not giving you benefit, then reconsider taking it, long term, round the clock, if it's not improving your quality of life. Some other medications to discuss that sometimes are used in arthritis. One of them is duloxetine. This is a prescription antidepressant medication that was actually also FDA approved for musculoskeletal pain, and it was studied in patients with osteoarthritis. And so, again, this kind of goes back to some of the interactions between your mental health and pain and arthritis, but we don't know exactly why this helps, but we do know that it can help patients with their pain. But of course, this can have other side effects too. It can cause dizziness, sleepiness, irritability. I mean, things that are, it needs to be discussed before starting. And not everybody's going to tolerate it either. But something that may be an option if you can't take the NSAIDs and the Tylenol's not working and you're really looking to try adding something else, there is that option out there. Topicals. I will say that generally speaking for hip arthritis, topicals are not always my go-to just because of the pure size of your hip joint, the amount of muscles and tendons that overlay your hip joint. You're not going to get a lot of probably as much benefit, and how deep the arthritis is, inside that hip joint and how surrounded it is by bone and muscle, that the topicals are not as effective. But these may be helpful for other arthritic conditions, osteoarthritis of the hands, osteoarthritis of the knees, and that would be things like diclofenac gel. That's the active ingredient. It's actually an NSAID like the oral, but is generally safer for patients that have some of those comorbidities that don't allow them to take oral. You may be able to take these topicals at a much safer, lower risk. So not to say that there is zero risk associated with them. There are definitely risks associated with them, but it's much, much lower because you're not orally absorbing that medication. So again, something to consider, but if you're going to be using it long-term consistently, definitely worth talking to your doctor to make sure that it's actually helpful. Another option is menthol products. Those are kind of your muscle rubs, for lack of a better word. They kind of increase blood flow to those areas and make it feel better, distract this pain sensation. They're a little more short-acting, so may not give as much of a prolonged benefit, but sometimes helpful for patients in the short-term use. Other options, again, not so much on the hip, maybe more knees and back and things like that, are lidocaine or capsaicin products. Lidocaine is actually the anesthetic or numbing medicine that comes in like when we numb up your teeth for a dental procedure. And so that comes in a topical patch or cream form. And that sometimes helps for other arthritis. Again, hips, I would say not as beneficial as some of these other options, but definitely something you could look at over the counter. And then capsaicin is actually derived from the red hot chili pepper. So same thing, it kind of irritates and affects the nerves, distracts the nerves. But the risk of that is you really don't want to use it on anywhere that's got an open skin lesion, or you don't want to use it on your hands because then you could get it in your eyes and it's very uncomfortable as well. Note on corticosteroid injections. There's a lot of good studies about the benefit of corticosteroid injections. However, they are not without risk either. Typically, the hip injections are done under ultrasound guidance, and whereas some of the other joints like knees, especially, are done off bedside, not always using ultrasound guidance. Again, how long was the benefit going to last? It really can depend on the person. Some people will get no benefit from them. Some people can get a week. Some people can get 3 or 6 months. It's just hard to know unless you try. Risks of that, especially with repeated injections, there's always a risk of osteonecrosis of the bone or dead bone, essentially. Insufficiency or stress fractures. There's risk of progression of the arthritis, making it worse. And then, of course, anytime we poke you from the outside in, infection or bleeding. Generally, it's still a very low risk procedure, and people don't tolerate it without much complication. But another option to try prior to surgery, or if you're not a candidate for surgery. I do want to talk a little bit more about other injections that I didn't put in my note, my slide, but that I kind of sometimes get asked about. That would be things like the stem cell or the platelet-rich plasma. Generally speaking, at this time, I don't feel that there's enough high-quality, consistent, randomized studies that I would generally recommend these for patients. The way that these types of things are prepared, the methods of which they are done, there's not a lot of consistency or clear evidence compared to placebo that I would say that I recommend them regularly to my patients. So just be aware that that's not really something that the data supports. Same thing, something I forgot to mention earlier in the oral medicines is the supplement aisle. Supplements are not randomized controlled studies. They've not been tested in the same nature that prescriptions and other medications are approved. And so the data out there actually really doesn't show that there's much of a difference or improvement in supplements for patients like glucosamine, chondroitin, or turmeric or things of that nature. That said, I have some patients that come in and tell me that they swear it helps, and I don't have a problem with my patients trying them and taking them if they really feel it's helpful, and they're pretty low risk. So again, the worst case scenario, it's just some money that you spend and it might not work. Best case scenario, you might get some benefit from it, but I wouldn't say I generally consistently recommend them to my patients for their hip pain. And then like CBD products, I also sometimes get asked about that. The problem with CBD is that there is no lack of standardization in preparation of CBD products and how much is in the dose and the strength and all that. And some of them even can contain a little bit of the THC, which can show up in a drug test. So I kind of, again, don't really recommend CBD products across the board, but I wouldn't have a problem with someone taking it if they really told me, hey, I want to give this a try. Just be aware of that. Kind of look for a reputable manufacturer when you're going to use it, and really just be wary that it may or may not, there's not enough evidence, I would say, that I would consistently recommend it for a patient. There still is research being done in terms of other disease modifying treatments for osteoarthritis, but they are very early in the stages, and I wouldn't even say that it's enough to talk about at this point, just because of how far out it really is from the consumer use at this time. And then just another note about our narcotic pain medications. We really don't recommend chronic narcotic pain medicines for chronic pain disorders, including osteoarthritis. Studies have shown that it really does not provide a significant improvement of pain on a consistent long-term basis. Patients typically may initially feel benefit, but they develop tolerance and dependence, and they also are high risk of, accidental overdose and things like that. So they may be prescribed in the acute post-op setting, depending on your surgeon and depending on when appropriate, but they should only be taken as prescribed, and we don't recommend them for long-term use. I guess the key takeaways that I have here are just optimize your non-pharmacologic options, your exercise, your weight loss, Tai Chi, and other things that can help you with your mental health and help decrease the pain. Safest over-the-counter medicine is Tylenol, but you got to keep the dose under 3,000. And if it's not helpful, I wouldn't say keep taking it. And then really, I would say when to see a doctor or a healthcare provider, PA, about your joint pain is if and when you start noticing that pain is limiting what you want to do. If and when you're considering taking these medicines on a more consistent basis. If or when you want to know if you're a candidate for surgery, those are all good places to start. I'd say start with your primary care provider. They're really good at weeding out whether you need to see orthopedics or rheumatology. Normal osteoarthritis of the hip, osteoarthritis of the knee, they can manage a lot of these non-pharmacologic options as well. But there are certain instances where some autoimmune conditions or rheumatologic conditions can present as hip pain as well. So, I would say have that discussion with the primary to determine if they feel that that's something that you need to see rheumatology for. But we are always happy to give advice and talk about all the things we just talked about with you if necessary. And that's just some of my references. So.
Thank you so very much, Kaityln. What a fantastic presentation. It is so important. I love how you addressed a lot of the kind of mental components too to the pain that many folks have to bear the burden of. So thank you so much.
And I especially love talking, but I can't hear you or see you.
I am talking. Hopefully everybody can hear me okay. Can everybody hear me?
Yeah.
Okay, good. Well, thank you very much. It was a wonderful presentation. You did a fantastic job. And I especially love your focus on the supplements, because I think that is so important. We tend to see as consumers a lot of commercials, just a lot of information that is out there. And I think it's important to understand, more of what the actual supplement can do or cannot do, and is it worth it and not worth it. So thank you very much. Hopefully you can hear me, because coming up next, we have our live Q&A. Again, many folks had sent some wonderful questions upon registration. We have received those. Our presenters for today have received those as well. So thank you so much. We're going to bring Dr. Harmon back. There he is, right on cue. And I'm going to go ahead and start posing some questions. And we'll go from there. So one of the first questions that I did want to ask, and I think Dr. Harmon, this may be most applicable to you. One of the questions that we had posed is, what happens to you physically should you choose to live with your hip pain or live with your joint pain? Is there any kind of serious damage that you can create to the bones by not doing a procedure?
No, as I kind of mentioned in my talk, I tell patients, you let me know when you're ready for joint replacement. If you can live with the pain, you can live with it forever. It doesn't, there's nothing that you can do to the hip that we can't fix eventually. Now, obviously, everything within reason, certainly, right? So if it's some type of congenital problem, if there's some type of, decreased blood supply to the hip, there's certain conditions that we would recommend, hey, probably sooner rather than later. But a run-of-the-mill osteoarthritis or degenerative arthritis, if you can live with the pain and you're doing things that you want to do in your life and, don't want surgery, that's fine. You don't ever have to have surgery.
Okay. And there would be no kind of consequential, nothing that would be ruined or made worse by not doing it.
Correct.
Okay. Awesome. Wonderful. Thank you for that question, John. One of the other questions that we had received are about labrum tears. And is that something that's curable? And what would that feel like in the hip?
Again, to me?
Yes. Yeah. Sorry.
Okay. All right. That's all right. So, I mean, it really depends on the age, and then also is there associated arthritis. So labrum tears can be treated if it's a younger patient, can be treated with number one, conservative measures initially. And sometimes those, like a labrum tear, just because you have a labrum tear doesn't mean you automatically have to have an operation. So in degenerative arthritis, just like degenerative arthritis of the knee, the meniscus, you could have degenerative meniscus type tears. Same thing in the hip. If you have arthritis, you could have a degenerative labral type tear. So a lot of times patients will have an MRI when they come into my office, but they won't have an x-ray completed. So if I get an x-ray and it shows end stage arthritis, but then, the MRI, they say, well, I have a labral tear. It's not really the labral tear that's giving you the pain. It's more the arthritic pain that's giving you, or the arthritis that's giving you the pain. So obviously it's very, patient dependent, depending on age and those types of things. But most of the time, if it's an arthritic condition causing the labral tear, we treat the arthritis, not the labrum.
Okay. Now, here's kind of a follow-up question to that is during a hip replacement, does the labrum get removed?
Yes.
Okay.
Completely removed.
Okay. Excellent. Thank you so much. Kaityln, I know that you did address a lot of the questions that we had regarding injections and CBD, but one of the questions that we had, and you had also addressed the topicals, but do you have any kind of opinion on adhesive patches for hip pain?
I generally say it's worth a trial. If you're, again, not a candidate for surgery or looking for ways to manage the pain, I think that there's definitely a use of them, and I think that some patients find benefit from them. Worst case scenario, you try it and it doesn't give you any benefit. You're out a few bucks, but best case scenario, it does give you some good benefit. Then I would say, by all means, utilize it. It's pretty low risk in terms of risks from those types of things.
Okay, wonderful. And then I do have another question for you in regards to, I know we tend to talk a lot about NSAIDs or supplements, but how about diet? Is there any kind of diet or food that helps to alleviate pain or can help prevent any kind of deterioration that you would recommend?
So generally speaking, I would say that diet is helpful to, a healthy diet is helpful, but I wouldn't say we have data to suggest that a certain diet can slow progression of the disease or, that type of thing. Generally speaking, especially for some of my rheumatologic patients, we have a lot of inflammation and so there is inflammation in osteoarthritis. Theoretically, patients could try an anti-inflammatory diet, especially those that are pretty motivated to make lifestyle changes. It can be a pretty restrictive diet, and it cuts out a lot of pretty enjoyable foods. So, again, it's kind of for someone that's really looking for that, but I think it's worth a trial again. I don't know that the data there is high quality or, there's not a lot of good ways to study diets because they're so variable, but I think that some patients do find some benefit if you cut out a lot of those processed carbohydrates and focus a lot on vegetables and lean meats. And like I said, too, the Mediterranean diet is one that is considered to be an anti-inflammatory diet. There's a lot of literature out there on its cardiovascular benefits as well. So something to consider if someone's interested in a diet.
Excellent. Thank you. Dr. Harmon, one of the questions that we had received for you is it common to have hip pain travel down the leg or perhaps move outside of areas outside of the hip?
So when the hip becomes arthritic, it gets inflamed, and there's a nerve that runs directly across the front of the hip joint. It's called the obturator nerve. That nerve supplies sensation down to the level of the knee. So a lot of times not a lot of times, but many times patients will come in, they'll just have strictly knee pain, and you do an x-ray of their knee looks fine. And then you do an x-ray of their hip and their hip shot. So, that's a tough sell telling somebody strictly with knee pain that you need a total hip replacement, but certainly that happens from time to time. Usually when people have pain that radiates down past the level of the knee, there's nothing in the hip that could independently cause that. But when people do have bad hip arthritis, they tend to want to flex their hip up, and then they start bending at their back to get their foot on the ground. So that could aggravate the back in itself too. But isolated hip arthritis does not cause pain that radiates past the knee, but it does cause pain that radiates to the knee itself.
Okay, excellent. Now, Dr. Harmon, another question that we had, and I know you and I were speaking on this earlier, you had addressed this, but I just want to kind of make sure that it's a very clear-cut answer in regards to any kind of age limit for somebody that's looking for a hip replacement. Is there a cutoff? Is it individual? What would you say to somebody coming to see you based on their age?
Yeah, so no, there is no, I wish I could give you a clear-cut answer on that, but we, I mean, as far as patients presenting to the office, I tend to treat patients based off of physiological age, not chronological age, right? So if somebody's independent, does all the things that they want to in their life, and this hip pain is the only, or hip or knee, whatever it is, pain is limiting them from doing things that they love, and is causing them pain every day, waking them up at night. They've exhausted conservative options, and they're still medically okay to have a total joint replacement. I certainly would say, let's have this discussion. Let's talk about it. Let's talk about the risks, the benefits, and make a decision together. But I don't particularly have an age cutoff, no.
Okay, so more on the individual, that is a clear-cut answer. If you can have one, that's it. It's based on you, the individual. So that is good. Kaityln, one of the questions.
It's medicine, so.
That's right. Kaityln, one of the questions that I have for you, are there any advances in non-surgical treatment of generalized osteoarthritis?
Yeah, and so I kind of touched on this a little bit. I don't think that we have any yet. In the past few years, especially in rheumatology, we've done a lot of focus on like disease modifying treatment, meaning and so we have a lot of these types of medications for autoimmune and rheumatologic conditions, but we still don't really have any for osteoarthritis. But there is a lot of stuff in the books. Everyone's looking to find a new treatment for osteoarthritis, because if there was something we could do to disease modify the course, then definitely everyone wants to make that medicine. So it's still being looked into. I wouldn't say that there's much more other than what I touched on that's really like new or breaking. Maybe Dr. Harmon knows of something that I don't, but I would say generally speaking, we're still kind of pretty much what I spoke on that I know of.
Dr. Harmon, anything to add in regards to that, or do you feel the same in regards to any advancements in non-surgical treatments for osteoarthritis?
Yeah, so I know she brought up a little bit about PRP and stem cells, and I just don't think it's there yet. I'm not saying that it's not gonna be. That's how medicine advances. That's how things progress forward. But at this point, there's no really good randomized controlled studies, at least out of North America, that show that there's any way to stop the progression of hip or knee or degenerative arthritis with, these stem cell injections or PRP injections. There's some anecdotal evidence, but I think until there is like a good study, I certainly don't offer that to patients as like a routine treatment option for degenerative arthritis of the hip or knee. And it's also very expensive, and I have a hard time saying to somebody, hey, it's a coin flip if we're going to hit a home run on this thing or not, and it's going to cost X amount of dollars. That just doesn't seem like the right thing to do. So until it's there, I shy away from them.
Okay. And one of the other questions, Dr. Harmon, I'm going to send your way is there a risk, let's say that, you have this procedure, you have a hip replacement done, and then you have a trip that's via plane, or I guess even in the car post-operatively. Is that a risk? Is there any kind of risk for a potential blood clot, or would you advise somebody to not travel for a sizable duration after a surgery?
So This is a question I do get a lot of in the office too. And I base it individualized, right? But I also say that, like, as long as you're up and moving and you're able to get up throughout the trip. So say it's a, hour flight or 2 hour flight or something, like, as long as you're able to get up and move, pump your ankles, have some mobility during that, and then also taking some type of blood thinner in order to prevent blood clots, like, I'm okay with traveling if you feel like you're able to do that. Now, usually, like I said, I see people back at the 2-week mark, but there are patients that come from out of state and those types of things. So I let them travel home. I just tell them to stop often, make sure you get out, move your legs, stretch your legs, wear compression stockings, and then also have them on some type of blood thinning medication to prevent a blood clot from happening, specifically in the setting of somebody that's had one in the past. So yeah, I mean, it is a risk, but at the same time, if you do things the right way, we're able to mitigate those risks.
Excellent. Thank you. Kaityln, one of the questions that we tended to receive a lot during the event was in regards to appropriate exercises after hip surgery. And obviously somebody would be working with a physical therapist, but is there any kind of recommendation there or anything that should be avoided after or during the recovery, even 1 to 2 years after somebody has a hip replacement?
So in terms of post-op, I really do not see a lot of post-op patients, so I wouldn't feel comfortable on advising on post-op exercises, maybe Dr. Harmon. But in general, just pre-op, like I said, it can be pretty much any type of exercise that you're comfortable with. But I don't really know the answer to the post-op question.
I'm sorry, it was breaking up there a little bit. Was the question for what to do pre-op or post-op exercises?
Post-operative, is there anything, any kind of exercise to avoid?
So I guess specifically for a direct anterior approach, I usually limit what a repetitive straight leg raise is. Not that you can't straight leg raise afterwards. What I mean by that is lying flat and then lifting the leg straight up off of the bed. You're okay to do that. I just don't want you to do it like 970 times afterwards. And the reason why is because we're using a retractor that's directly under the flexor tendon of the hip. So sometimes that tendon can get irritated if you do a lot of repetitive hip flexion or repetitive straight leg raises. So I say no repetitive straight leg raise, no repetitive marching for 6 weeks after the operation. Doesn't mean you can't do it at all, but just not a ton of it.
Okay. And another question that we had, Dr. Harmon, are hip replacements a good idea for someone with Parkinson's or someone with MS, or would you avoid this surgery?
That's a difficult blanket question for me to answer. I think, I think, again, it's individualized on the patient, but certainly there's ways, if it's a consideration of dislocation or those types of things. I think, number one, good positioning of components helps limit those risks or at least decrease those risks. And then also, I do believe that an anterior approach decreases the risk of dislocation, specifically in somebody that has those flexion contractures or internal rotation contractures. So I think if it's necessary and it's something that's going to make people feel better and they've exhausted conservative options, I don't have any qualms about doing the total hip procedure, but I think that it does have to be kept in mind that they're at increased risk of dislocation, but doing the right things at the time of operation to decrease those risks is what you have to be cognizant of.
Okay, thank you. Kaityln, one of the questions that we had received upon registration for today's event was on sleep positions. And are there any kind of positions to avoid or to really try to get yourself in the habit of doing to alleviate joint pain?
So in terms of sleep positions, I don't think that I've ever actually received that question. So I've not done much reading of that in terms of if there's any studies out there. I do know that sometimes patients with hip arthritis do experience a lot of night pain. It can wake them up at night if it's severe or advanced. But I don't know that I know of any specific positions. I would say find what feels comfortable and what will help you, achieve a better night's sleep. Sorry, I don't have a good answer on that one.
No, it's okay. And then one of the other questions that we received is in regards to any kind of like massage, like is there any research or indication that a massage and getting frequent massages might help alleviate any of that pain?
I've seen the data I've seen on massage is that it's generally pretty small studies. There's a fair amount of bias involved in them. So not that there's not been studies done. I do think there's possibly some benefit from massage, but again, that's something I would routinely recommend to my patients. There's just, in terms of a blanket statement for hip arthritis, I wouldn't say that it's probably going to be a huge benefit, but if you have the means and would like to try it, I don't think there's a reason not to, especially in, normal osteoarthritis.
Excellent. Dr. Harmon, I have one more additional question for you, and it is in regards to, let's say that you need to have a hip replacement on both sides. Is that something that is going to be done at the same time, or what's the duration between the two that you would recommend?
Yeah, so no, we do not do hip replacements at the same time typically. Usually I say, pick the one that hurts worse. If they're equal, then, we could just flip a coin basically, right? And we could just say, okay, let's do this one first. And then I tell patients, see me back at the 2-week mark. Let's see how we're coming along and see how you're feeling on that side. Sometimes when you have a good wheel and you're able to put more pressure on that leg, the new total hip side, the other side stops hurting you. So, I don't stage them right off the bat, but I say at 2 weeks, if you're happy with the total hip that you just had done and you want to proceed with the next one, I don't have any issues doing that within a 6-week period of time. Just really depends on if it's still hurting you, if it's feeling better, or if you say, hey, listen, it was great on this side, I want to move forward with the other side. I'm okay with that within a 6-week period of time.
Oh, okay. Excellent. And then, Kaityln, I have one last question for you. When would somebody, when you're struggling with joint pain, hip or other pain, when is it time to go and see somebody in the Rheumatological Institute? When is that kind of time? What is that pain threshold? How would you advise somebody?
Yeah, so, I think a lot of it comes from kind of the nature of your symptoms. If it's purely hip and knee pain, it's very classic, like worse when you get up from a seated position, standing, mechanical type joint pain. Your x-rays say osteoarthritis. It's very classic, straightforward osteoarthritis. I don't know that we're always happy to see you and look over and see if there's anything more we can advise. But in terms of, long-term management, it's a lot of what we talked about. The patients that really should be seeing rheumatology, especially, and if we're here to help you figure it out. So we can help you make sure there's not an underlying autoimmune or rheumatologic condition. But symptoms that I definitely think should see rheumatology are a very prolonged period of stiffness, especially upon waking in the morning. Not just a few steps to get moving. We're talking, 30, 60 minutes or more. Affecting more than one joint at a time, or maybe the severity of your symptoms cannot be explained by the amount of x-ray findings. Like say you have a lot of pain in your hips, but the x-rays are relatively normal and doesn't look like you would even be a candidate for hip replacement surgery. Someone like that would be worthwhile to see rheumatology. And then a lot of if you get intermittent, unexplained joint swelling, knees here or there, those types of things. And then also patients that have other conditions like inflammatory bowel disease, ulcerative colitis or Crohn's or psoriasis. Some of those conditions can be associated with some axial or hip pain. So I would say those are the people that definitely should be seeing rheumatology.
Excellent. Thank you so much. Dr. Harmon, I know I said I finished with you, but I am noticing that there are several questions on where you're located in Cleveland and what offices you are at. Can you elaborate just a little bit more on your locations here in Cleveland?
Yeah, so see patients at Twinsburg, the Family Health Center there twice a week, and then Solon once a week.
Wonderful. Wonderful. Thank you both so very much for your time today. I cannot thank you enough on this presentation. Just some of the feedback that we're receiving that this has been tremendously helpful. And I strongly recommend those that are interested in learning more to take a look at some of the resources that we provided in the Q&A. We also have an arthritis handout that is available here. At the end of today's presentation, in the coming day, I would say, there will be an email with a recorded link to view this lecture at any time, to share with your friends and family. I know we received that question a lot as well. So this recorded lecture will come out. It will be sent to you via email. So please stay on the lookout for that and share. And then again, thank everybody. I want to thank everybody for attending today, for viewing, and for staying with us. And of course, our two wonderful presenters, thank you very much. It means a lot to everybody in attendance that you took the time to do this. So thank you.
Thanks for having us.
Thank you all very much.
Thank you, everyone, and have a wonderful rest of the day.